So that is, so now we go to the questions which younger students will have to ask. How to diagnose viral meningitis? So can bacterial meningitis mimic viral meningoencephalitis? So these were the queries which started from emergency to senior postgraduate to junior assistant to head of the department to neurologist. So we will ask all these things: how to diagnose viral encephalitis? Can bacterial meningitis mimic viral meningoencephalitis? Can previous antibiotic treatment affect CSF interpretation? How to differentiate viral encephalitis from partially treated bacterial meningitis? And if CSF become traumatic, how to interpret the CSF finding? How to rule out TBM in such cases? And when to suspect fungal and syphilitic meningitis? And how to rule out these conditions. So this we will learn in the course of the discussion. So there is confusion. There is no need for us to feel frightened, because confusions are there clinically, confusions are there in the laboratory. So finally, we make diagnosis using induction, experience, and clinical presentation as well as the course of illness. So laboratory features of meningitis. So when we when a patient comes with features of acute meningitis like this, in the blood, what are the tests that we have to do? It is called 3 C's. In the blood, we will do 3 C's. One is take the blood for culture, then do the cell count, then do the CRP. From this, I will say how to derive at the differential diagnosis which went up from the emergency doctor level. So in the blood, 3 C's test is done. One is culture, second is cell count, third is CRP. That is 3 C's. Then you do the CSF. If all this is done, the queries will be answered. That will go through. So look at the opening pressure. The opening pressure is always raised in bacterial meningitis. So that's the first clue. Opening pressure is always raised in bacterial meningitis. Then look at the color. It is usually cloudy. Check the cell count. Glucose and the ratio of the blood glucose. CSF glucose to blood glucose level, you should calculate. If the patient is a diabetic, CSF glucose will be high. Still, it might indicate really low glucose. Then, on the blood glucose should be obtained before the lumbar puncture. Then look at the CSF protein. Do the gram stain, culture, and optional, not always, you can do lactate, ferritin, and LDH. And you can do the rare test in that order if it is indicated. So that I will elaborate. So other rare test, you just keep the 5th sample, which we will do if needed. Then you have to do body fluid culture. If you have ascites, or if you have ear discharge, if you have pleural effusion, cardiac effusion, petechium, sputum, nasopharynx, oropharynx. So all these body fluids, if available, should be taken for culture. And another important thing to remember, do not do the lumbar puncture today and send the sample tomorrow. Never refrigerate. Organisms die if transmit time is more than few minutes. You keep it in the fridge for 2 hours and send it as a lump sample, nothing will be useful. And WBC reduces by 32% in 1 hour and 50% by 2 hours. So the cell count will change, everything else will change, culture will become negative. So it should be immediately sent to the laboratory. So when you do the CSF, what are you going to do? You have to take 5 test tubes. You have to take 5 test tubes. The first one is for RBC, WBC, and differential count. Second one is for protein, glucose, and simultaneously compare with the blood sugar. Third one is for culture for the various organisms. And the fourth one is for the various stains, which you should never forget. India ink stain, gram stain, AFB stain, and other stains are usually done, but do not forget India ink stain for cryptococcal meningitis. And the fourth sample is what I said, which is non-mandatory test, which will be done in difficult situations. So 5th sample is kept like that. In case you feel it is indicated, you will use that sample. So 5 samples should be taken. So now we have asked some questions. So what are all the clues? Even though all these clues will not be always useful. So supposing your patient's acute meningitis is bacterial due to meningococcal meningitis. Then patient, there is a rapid evolution of symptoms with delirium, stupor, purpuric rash, ecchymosis, that ecchymotic patches, and libido reticularis. And there can be associated circulatory shock due to adrenal involvement. So even if you don't get the organisms, if the patient has rash, ecchymotic patches, and he goes into hypotension and shock, then you can think it is probably meningococcal meningitis, and without waiting for the culture, start appropriate antibiotic. Rashes can also be seen in echoviruses and Staphylococcus aureus infection. The pneumococcal meningitis usually associated with upper and lower respiratory infection or artificial heart valves, splenectomy patients, autosplenectomy condition like sickle cell anemia and alcoholism. And if there is associated cranial nerve palsy, think of tuberculous meningitis, but H influenza meningitis can present with, even though it's an acute meningitis, it can present with cranial nerve palsy. H influenza typically produces an otitis. It produces an acute otitis, so ear pain, otitis, and then they get into bacterial meningitis. Then you think of H influenza. That is one bacterial meningitis of acute nature which can produce cranial nerve palsy. Otherwise, cranial nerve palsy is a feature of chronic meningitis, not in acute meningitis. Then influenza meningitis is seen in children following END or upper respiratory infection, and it can produce seizures and cranial nerve palsy. And also it can produce subdural effusion. Then if the person is having cutaneous infections, pharyngilosis, coagulase positive staphylococcus is suspected. And patients with ventricular-atrial shunts are prone for coagulose negative staphylococcal infections. So these are some clues. Even when you are waiting for the culture, look for the circumstantial evidences. If these circumstances are present, you can start the appropriate medication. And rare infections are common in immunocompromised patients like HIV or non-HIV related immunosuppression. So this is taken from the reference which I have put there, R.D. Adams. And clear CSF is very rare in acute bacterial meningitis. If clear CSF is there, it is more common in viral meningitis or sometimes even tuberculous meningitis, but it is very rare in acute bacterial meningitis. In bacterial meningitis, WBC count is usually very high, nearly 1,000, or a small proportion only will have less number of counts. But in viral meningitis, it is not that much high, it is around 100. But you should be aware because all these are sensitivity, specificity, and so you cannot take this as 1:1. And lower counts of cells may be found in children and immunocompromised persons. And CSF can be completely acellular in pneumococcal and meningococcal meningitis. More than 10% of bacterial meningitis can have lymphocyte dominance. Because lymphocyte is dominant, it is not always viral. That is why I said when the hierarchy increases from the emergency doctor, there is not much doubt at all. But when you go to the level of the head of the unit of medicine and neurologist, then the confusion increases because of these pitfalls in the laboratory data. So more than 10% of bacterial meningitis, lymphocyte can be dominant. So even lymphocyte dominant does not say it is viral. And early in the course, even in chronic meningitis, people can have polymorph. So just because you see polymorphs, it does not exclude a chronic meningitis. Just because you see lymphocyte, it does not exclude an acute meningitis. So all these confusions will come as the knowledge base increases. So early stages of tubercular or fungal meningitis And few viral meningitis can have polymorphic pleocytosis. That is called acute phase reactance. So when there is an infection, there is an acute phase reactant. After that, it will go and it will become lymphocyte dominant. So if you are doing the LP at that phase, the confusion will be more. So what are the effects of partial treatment? It is the commonest presentation in a teaching institution, partially treated as a pneumonia or chest infection that will act on the CNS also, but the dosage is for the systemic infection and not for the CNS infection. So what you should know, in the CSF, partial treatment does not alter the WBC count. It does not alter the proteins or the sugars, but it will alter the culture and polymorphic response. So the total count does not change, but the polymorph might become lymphocyte. And CSF protein and sugar does not change, and culture might become negative. So partial treatment alters the culture and alters the type of white cells in the CSF. So protein values less than 220 milligram is common with viral meningitis. In bacterial meningitis, it is always higher. It is 100 to 500 milligram per deciliter. In acute bacterial meningitis, sugar level is usually less than 40. And the ratio between the blood glucose and the CSF, blood glucose and the CSF sugar less than 0.23 is a very useful predictor of acute bacterial meningitis. But it can be normal in bacterial meningitis also. So if the sugar is very low and cell count is polymorphic and proteins are marginally elevated in a patient with acute bacterial meningitis, it is very useful for you. But if it is not there, it does not exclude. That is what is the inference. All patients evaluated for suspected meningitis should undergo a gram stain examination of the CSF. And it is very useful. And immediately you get the result also to pick up Staphylococcus pneumonia, H. influenza, Neisseria meningitidis, and other gram-negative bacteria and listeria. So without waiting for the culture, your differential diagnosis of the type of infection will become narrow when you do the gram stain. And 70 to 90% in non-treated bacterial meningitis, culture positivity is there. But if it is partially treated, culture positivity drops to less than 50%. So the New York test, I said the fifth sample. We have got the fifth sample in the test tube. We have kept it. If needed, we will use it. It is not a mandatory recommendation. So here, this is latex agglutination test. It is sensitive for Staphylococcus pneumonia, H. influenza, Neisseria meningitis, and it is highly specific also. It is not available in all places and it is not mandatory recommended. If all other tests are becoming negative, then you can consider these tests in the fifth sample. Then Infectious Disease Society of America practice guidelines does not recommend routine use of these investigations. Limulus amoebocyte lysate, that is also not routinely recommended. So these are the fifth sample is kept for this less recommended investigations. That is for gram-negative meningitis, and sensitivity is nearly 100%. But it is very rarely available in the rural medical colleges or leave alone rural hospitals. So it is all for the fifth sample only. And PCR for simultaneous detection of Neisseria meningitidis, Haemophilus influenza, Streptococci, and with a very good sensitivity. And a broad range of PCR can detect small number of viable and non-viable organisms. So PCR can detect viable and non-viable organisms even if they are present in a very small amount, but it is costly, it needs expertise, it needs availability. So this is all in the fifth sample. So WHO has been, so if this is done in patients who have been pre-treated, so partially treated cases where you do not know, you start anti-tuberculous also. patient is developing hepatotoxicity. It is all started by the 5th level recommendation of rare presentations of tuberculous meningitis. Maybe it is not at all. We thought this case is finally viral. So when are you confident enough to withdraw? So at that phase you can do the PCR and all other tests are not helpful. Those situations, the 5th sample is used for excluding with more confidence and discontinuation of antimicrobial therapy or anti-tuberculous therapy. So in difficult situations, partially treated, you have started everything together. We saw how we approached from the emergency to the neurologist. We started everything together. Now we want to know what all can be stopped, what all are not necessary. That information is obtained by about 3 to 4 days from the way the patient is responding. That time to withdraw the drugs, we can use the 5th sample and do the more complicated test. The other extended tests are looking for bacterial genomes using broad range rRNA PCR, nucleic acid hybridization and restriction fragment length polymorphism, and serological markers like lactate, CRP, procalcitonin, cytokines, and rapid culture methods. Procalcitonin is very useful, and serum procalcitonin concentration is very sensitive in children, and in adults serum concentration of 12.2 nanogram per ml has a very good sensitivity and specificity up to 100% of bacterial meningitis. And according to meta-analysis, C-reactive protein for diagnosis of acute bacterial meningitis, it also carries a good sensitivity. So difficult situations combine clinical picture with multiple laboratory data and sometimes use the 5th sample to exclude or withdraw unwanted medications. And CSF lactate, this is also superior to CSF blood glucose ratio in post-operative neurosurgical patients. More than 4 millimoles per liter of lactate suggests bacterial meningitis and not viral meningitis. A normal CRP has a high negative predictive value. Normal CRP is not seen in bacterial meningitis. So if you see a normal CRP, it is probably viral and not bacterial. So this is how we finally confirmed that our case number 1 is viral. So other helpful and indirect diagnostic markers of acute bacterial meningitis are elevated serum CRP and increased CSF lactate and high CSF ferritin. These are not mandatory recommendations. So these are done in the, when you reach the higher hierarchy and there is confusion, partially treated cases. So when are you going to withdraw the other antibiotics? So then bacterial antigen detection using LPA, ELISA, counter immune electrophoresis, and all these tests have higher sensitivity to detect the bacterial antigen. Then currently available PCR methods have very high sensitivity, and fluorescence in situ hybridization is less sensitive but may be useful for identification of bacteria and CSF sample in some cases. So these are all done in the 5th sample to decide what are all the medicines which you are going to withdraw. Then what is the difference between ventricular CSF and lumbar CSF? You are suspecting meningitis, lumbar CSF is not coming due to some reason like very high CSF protein or you have a block, then we may do ventricular CSF, usually done in children. Normally, there is a gradient of rising cell count and protein and falling glucose from ventricles to lumbar. In the ventricular CSF, cell count is more. In the ventricular cell count is more, glucose will be falling when you reach the lumbar region. And so there is a, normally there is a alteration in the cell count and protein in an upgradation way from the lumbar CSF to the ventricular CSF, and blood glucose falls from the lumbar CSF to the ventricular CSF. In acute bacterial meningitis, what happens? Gradient for cell count and protein is there, but not for glucose. No difference in the differential count. So in acute bacterial meningitis, this gradient of increasing cell count in the ventricular CSF, increasing protein in the ventricular CSF, and decreasing sugar in the ventricular CSF. That is the normal. Increase cell count, increase protein, and less sugar in the ventricular CSF. This gradient will be tilted, and for glucose, this gradient will be tilted for glucose, and the differential count remains unaltered. Cell count and proteins are normal in 12% of patients with acute bacterial meningitis, but all three were normal in 0 to 5%. So it can be completely normal also, and patient can suffer from bacterial infection. So it has a ventricular CSF has got a high yield for culture than the lumbar CSF, because it is meningitis, and meningitis is in the brain, and the spinal meningitis is less common. So ventricular sample has got a high yield for bacterial positivity than the lumbar sample. So now we are having a patient like we saw our case number 1. He is a suspected case of acute bacterial meningitis because he had headache, fever, and neck stiffness. Did he have a skin rash? If it is there, it may be meningococcal meningitis and other ecoviruses and staphylococcus we have discussed. So within 30 minutes, you look for the rashes, and if it is there, you think whether it is a meningococcal meningitis and start the treatment while the investigation results are awaited, and immediately transfer to a secondary care center from the primary health center. And if there is no rash, then you admit the patient to the hospital and evaluate for shock, DIC, GC score, focal neurological deficit, secure and IV access. All the 3 C's in the blood and the CSF, and the imaging is done, and assess the safety of the lumbar puncture and go ahead with that. Now, repeat CSF was ordered by the postgraduate in our case number 1, which I had discussed. So what all the things will happen to viral and bacterial meningitis when you repeat the cerebrospinal fluid? In viral meningitis, you will see that lymphocytes are dominant. When you repeat as an acute phase reactant, polymorphs may be high, but after some time it becomes lymphocyte. Cell count is always less than 1000. CRP is not increased. CSF lactate is not increased. Pro-inflammatory cytokines are normal, and CSF protein is never more than 250, and sugar decreases by 3.7%. That in the repeat sample is really educative, so it will reduce some of our confusions. So these features are pointing to viral. What happens in bacterial? In the repeat CSF, usually polymorphic pleocytosis is established. Cell count is more than 1000. CRP is elevated. CSF lactate is increased. Pro-inflammatory cytokines are increased. Protein is more than 35. And sugar is less than 95. So by repeat CSF was ordered by the senior resident. Is it correct or not? It is correct, because in the acute phase we had confusion whether it is viral or bacterial. So by repeating the CSF, we can get more inference. But in our given case, I said that it became traumatic. So there you have to apply the RBC WBC ratio in the blood to find out number of cells in the CSF. So this is the imaging picture showing the meningeal exudates. The typical imaging picture showing meningeal exudates. This is what you will see in meningitis. Meningeal exudates are there. So this is a trauma, post-traumatic meningitis, where the person has got a break in the ethmoid bone. So infection has gone inside and it has formed an abscess also. This is post-traumatic meningitis. Usually the defect, and you can see the CSF rhinorrhea. CSF getting into the nose, and the infection goes to the frontal lobe through the nose. That will give a clue that it is traumatic meningitis. In that case, the organisms may be non-pathogenic roadside organisms, which will be very resistant to treatment. And the course of the patient may be very serious, so it is of very prognostic relevance. Organisms may be unusual organisms. So next, post-treatment bacterial meningitis. What happens to CSF at the end of 2 weeks? It is not always recommended, but in some cases we do it at the end of 2 weeks if the patient still has symptoms. But remember that when you repeat the CSF after 2 weeks, in 10% of cases, CSF sugar can remain low. When the CSF pressure sugar remains low, we need not get alarmed, frightened, and start all the antibiotics available. And CSF protein, in 1/3 of cases, CSF protein level is more than 45 milligram per deciliter. And cell count, in 70% of the cases, it is more than normal. So at the end of 2 weeks, if the cell count remains high, protein remains high, and sugar remains low, there is no need to get alarmed. Actually, there is no recommendation to repeat a CSF in acute bacterial meningitis after 2 weeks, unless there is some kind of clinical suspicion like persistent constitutional symptoms. So next we will come to chronic meningitis. This is meningitis of more than 4 weeks duration. We saw an acute meningitis, which is few days. So whether it is viral or acute bacterial infections. So now what are the features of chronic meningitis? When the meningitis is more than 4 weeks, we call it as chronic meningitis. Intermittent fever, weight loss, appetite loss, night sweats, personality change, headache, fluctuating symptoms, cranial nerve palsy, and papilledema. So these are features of chronic meningitis. So now we'll come to case 2. Case 1, I have carried you from the emergency doctor to neurologist, their rationale, how to differentiate, and how to arrive at the final diagnosis or longitudinal follow-up. Case 2 is 37-year-old female, headache of 20 days, diffuse in the back of the neck. The headache was disturbing. It was severe in intensity, and patient had vomiting, and there was deterioration in sensorium, irrelevant talking, refusing feeds, gradually became incontinent and unconscious over 20 days, and reports minor improvement with symptomatic treatment and electrolyte imbalance correction. So antibiotics were started. So antibiotics and symptomatic measures, there is marginal improvement. Patient slowly develops blindness. He developed drooping of eyelids, and he develops right intracranial pressure. Plantars become extensors, and meningeal signs are present. And opening pressure is elevated. CSF color is clear. Acute bacterial meningitis, it is always cloudy, and chronic meningitis, it can be clear. Total count is around 500. All lymphocytes, protein is 259. Sugar is 25 milligram as against a blood sugar of 133. VDR India negative, malignant cells negative. So this is the imaging of the patient. There is a full dense exudates around the sella turcica, around the cisterns, and there is already ventricular dilatation and multiple ring enhancing lesions, the ring lesions, and dense exudates. So when you did the sagittal cuts, you are saying so many coalescing rings and the meninges all covered with the thick exudates. It goes into the meninges of the spinal cord. So this is tuberculous meningitis. So staging, one stage also. This is chronic meningitis, more than 4 weeks with typical clinical and radiological features. And stage 1 is apathy, irritability, headache, malaise, fever, reduced appetite, and vomiting. And stage 2 is altered sensorium and minor focal signs. Stage 3 is coma, seizures, and multifocal signs. Treatment as enteric fever with quinolones. This is a very common thing. Most of these patients will receive quinolones with a possible diagnosis of typhoid fever, and that will partially act on tuberculous infection and suppress some of the signs. So many features can have a subacute course with we said partial response. This patient also had partial response. He was treated with quinolones. So there was partial response because they are acting on the tuberculous bacteria also. So this we should remember. So the differential diagnosis, is it fungal meningitis, cryptococcus, common fungus comes from bird droppings. Is it spirochetal, Lyme disease, syphilis, leptospirosis, and is it bacterial, partially treated bacterial infections like uncommon bacterial infections like brucellosis, then parasitic infections like cysticercosis and toxoplasmosis, and viruses which can sometimes have a subacute course like herpes, mumps, and retrovirus meningitis. So when there is a chronic meningitis, the differential diagnosis is fungal, is it spirochete, is it partially treated? Brucella resembles tuberculous meningitis. So is it brucella and parasitic infections and viral infections which can have a subacute course. So that is tuberculous meningitis. One thing always remember, the streptomycin autotoxicity, INH retinotoxicity, INH peripheral neuropathy, and ethambutol retinotoxicity in tuberculous meningitis is not reversible. So when the blood-brain barrier is broken, ethambutol is a bacteriostatic drug, and but it will grow into the blood-brain barrier and it can produce blindness, which can be missed in a very sick patient. So it is better to substitute ethambutol with levofloxacin or ofloxacin in patients with tuberculous meningitis. Then the less common scenario, case 3. This is a 42-year-old young adult, immunocompetent, severe headache, no neck stiffness, poor vision, and had repeated syncopal attacks. Severe headache. This person had very severe headache and he had repeated syncopal attacks. His CSF showed lymphocytic pleocytosis, and there was raised protein, decreased glucose, and India ink stain was positive. So the most important thing is very severe headache with not much meningeal irritation, but poor vision. Severe headache and poor vision are important features of cryptococcal meningitis. And this patient, the cryptococcal meningitis was not initially thought of. When we did not get anything, repeated the lumbar puncture, and we found it. Then the patient told that he every day reads 1 hour newspaper in the veranda, sitting among the dove's droppings. So these are cryptococcomas, very small cryptococcomas, which we saw in our patient. And this is the CSF. India ink, somehow when the picture was taken, the background became pink instead of black. You will see the highly motile cryptococcus. Cryptococcus will be very active, very dynamic, whitish in the black background of these are white clusters. All this is cryptococcus. It is usually present in the droppings of birds. And it can affect immunocompetent person. Not always immunocompetent, it's very much fatal. So when you do not diagnose and a young healthy person comes with meningitis and dies, there are so many legal issues also and ethical issues. So this is cryptococcus, very bright like sun. And it will be very much contrast in the Indian. Just to put a drop of CSF and a drop of India ink and see under the microscope. Next is a 4-year-old child from some interior part of Tamil Nadu, headache, vomiting, low-grade fever, and muscle pain of 3 months duration. CT scan was done and locally reported as tuberculoma. CSF protein was 300 milligram, sugar was 40, lymphocytic pleocytosis, and clinically deteriorating with seizures and cranial nerve palsies. At that time, the patient came to us, and when we did the MRI, it was a starry sky. Typical starry sky of neurocysticercosis. Whole body is filled with the palisades of cysticercosis. That is why the child had severe muscle pain. You can see all the muscles of the legs, upper limbs, and this brain looking like a star, and muscles of the occipitofrontal, occipital belly of occipitofrontalis. All this is studded with the cysticercosis, and this is the squalex. when we saw it in the laboratory in this child. And because the child had muscle pain and the whole muscle MRI showed palisading lesions, we did a muscle biopsy for a meningitis patient. So this is an indication for muscle biopsy in meningitis, and you can see the cysticercus with a central dot. And in the biopsy, this was the sample. Then we went to the nearby meat shop and we saw the measly pork. This is how the measly pork looks with so many cysts around, and a small speck is taken and it is put in the petri dish with saline, and within 2 days you see so many daughters, so many. You can see the load of infection in a measly pork from a small area. Imagine what will happen if this is eaten. So clinical manifestation of cysticercal meningitis, wide variety of clinical manifestations, but seizures are very common. Headache, raised intracranial pressure, visual problems, psychosis, confusion, hydrocephalus, ataxia, cranial nerve palsy, meningitis, and strokes. So this is a use of skin. I said in the skin you can look for rashes, ecchymosis, and these are cysticercal nodules. Cysticercal nodules in the skin. We saw it in the muscle of that child. This is an adult having nodules in the skin. This can be biopsied. And this is a squalex. You can see the squalex. Seeing the squalex is the most useful clue. Inside the cyst, you see the squalex. Next is a 54-year-old female patient. She had headache of 7 months duration and behavioral abnormality with the frontal lobe features, steady deterioration, and initially started as mania, then excessive talkativeness, spending, donating, punting behavior, and clinically it looked like a rapidly progressive frontotemporal dementia. So, but the odd feature is the headache. Frontotemporal dementia can do all this, but it does not produce headache. So this person was referred from another area as FTD, frontotemporal dementia. Examination showed frontal lobe features. She had optic atrophy, and tongue showed the clue. You can see this tongue. This is a trombone tongue. Trombone tongue is seen in many conditions, including Wilson's disease, but in this context of meningitis, it is a clue for neurosyphilis. Then we examined her husband. He was positive, but he did not have meningitis. Whereas this lady contacted it from her husband, but she developed syphilitic meningitis. You can see the meningeal exudation. When we started her on penicillin, she went into severe reaction. Then we had to rescue her out of that reaction with high-dose steroids, withdrew the treatment for some time. She developed acute necrotizing encephalitis with penicillin. And then she was restored from that and then treated fully with a alternate regime, erythromycin. And then she improved, but she left with a lot of sequelae. So CSF showed lymphocytic. The clue is the tongue. In this patient, the clue is the tongue. So we saw clues in the skin. We saw clues in the muscle. Now this is a tongue as a clue. So lymphocytic pleocytosis, protein 134, sugar 60, serology positive, TPHI positive, in the asymptomatic husband also. So as I said, she developed acute necrotizing encephalitis, and at that time, this was the picture. She became very sick with penicillin, and then we treated her out of that with high-dose steroids. Because it was at that time I was working in NIMHANS. It's a tertiary level center or quaternary level center. Because of that, people forgave us. Otherwise, they will never know, and it can be very dangerous. Next is a 57-year-old male. He had headache, dizziness, low-grade fever, intermittent loose stools, and skin changes in the face. He developed nodular lesions in the skin and slowly developed memory problem, tremors, involuntary movements of the face, and family informed that he had gone on a pilgrimage 2 months before that. And these are the nodular lesions which are seen in Whipple's disease. So these are the nodular lesions. And MRI is not very characteristic diagnostic feature is there, but in our patient, there was hypothalamus and medial temporal involvement, flare hyperintensities in the middle cerebellar peduncle. And so all those things were there. Here you can see in the middle cerebellar peduncle, but these are not very specific for Whipple's disease, but that is what we saw in this patient. And this is the oculomastigatory myorrhythmia. This is the typical clue. The skin changes, meningitis, dementia, extrapyramidal features coupled with peculiar eye movements involving the eyes and the jaw muscles, which is called it as oculomastigatory myorrhythmia. Very diagnostic of Whipple's disease. Because these are all treatable provided the appropriate medicine is started. So this oculomastigatory myorrhythmia is a classical clue for Whipple's disease. Next patient is a 16-year-old boy from Orissa. He complained of non-pulsatile holocranial headache, low-grade fever of 3 months duration, and he was started on anti-tuberculous medicines at the local hospital, but he did not improve. He reported transient improvement of some of his symptoms, but deteriorated, developed hemiplegia, aphasia, and altered sensorium. There was no preceding history of seizures, myoclonus, dog bite, or vaccinations, or unsafe sexual practice, nothing was there. And there was no recent history of travel or water-related activities preceding the illness. On admission, he was febrile, drowsy, unresponsive to command. Neurological examination revealed neck rigidity, right hemiplegia, hypertonia, and bilateral extensor responses. We lost the patient, and this was the MRI findings. Multiple abscesses were there in the MRI. And this showed choline peak, and postmortem revealed the amoeba. So this was a primary amoebic meningoencephalitis in a young person who did not have any history of getting bath in a contaminated pond. So from where he got it, we don't know. This is the primary amoebic meningoencephalitis. So you have Naegleria fowleri, Balmutheria mandrialis, and Acanthamoeba species are there, and they produce purulent CSF, and it can be picked up in the wet mound itself. So and Acanthamoeba, it produces chronic granulomatous meningoencephalitis, and an immediate CSF sample like Cryptococcus, you can see that, and the lesions in the brain resemble toxoplasma. You saw the multiple abscesses which are in the capsuloganglionic region. So it can be mistaken as toxoplasma. In this patient, the atypical feature was a prolonged course, lack of exposure to contaminated pond, and immunocompetent. Still he got it. Next case is a 35-year-old person working in Gulf country, had features of chronic meningitis. Imaging showed white matter changes and meningeal enhancement, and investigations for TBM was negative. But he accepted that he had been drinking unboiled camel milk. So unboiled cow's milk and camel milk is a source of brucella. And so we got the clue, and he was investigated and turned out to be brucella. And next is a 47-year-old lorry driver who presented with all the features of meningitis, but we could not identify any of the organisms even in the sample 5. The 5th sample is for rare organisms, I told. All that was analyzed, it was all negative. So we did not know what was happening. He became very sick. At that time, his friend came, and he told that this person has got a peculiar feature of eating one animal monitor lizard. He thought that it gives a lot of energy for long distance driving. And so monitor lizard, it is called monitor lizard. He ate raw tongue, liver, gallbladder of this animal. And he also ate rat snakes. This history was revealed to us later when all the analysis of the sample 5 also was negative. Then we did investigation for angiostranguliosis, which is an infection of the monitor lizard which comes from the snails that it eats. So that was that's a very, very rare infection. So only when this history was obtained, that was tested, and he had eosinophilic meningitis, and angiostranguliosis was confirmed by immunoblot analysis, and this person responded to albendazole. It is due to the snail eating habit of the monitor lizard. And monitor lizard gets infected from the snail, and that gets into man when he eats that. And this was the MRI picture of the patient, non-specific changes. So we struggled to get a diagnosis. Only when the friend gave the history, we could get it. The CSF was cloudy, and this shows the organism. During the course of treatment, the amount of eosinophilia was very high, and then it reduced slowly during treatment. This is another condition. I am sure everybody knows this. Hydatid cyst, it comes from dog tapeworm. A boy presented with seizure, fever, altered sensorium, and this was the imaging finding. This is not seen in any other condition, large hydatid cyst. So what are the situations we get recurrent meningitis? Recurrent isolation of streptococcal pneumonia, Haemophilus influenza. If you find that in a person who presents with recurrent meningitis, suspect a CSF fistula. So there may be a CSF leak somewhere which is evident or not evident. So we'll have to look for when there is a recurrent streptococcal pneumonia, CSF rhinorrhea, artoria, all those things you have to suspect and close it. Otherwise, the meningitis will recur. Recurrent meningococcal meningitis happens in complement deficient patients. So if there's recurrent meningococcal meningitis, think of complement deficiency and look for that. Recurrent staphylococcal meningitis, dermal CSF fistulas. And treatment of underlying cause is the treatment of these meningitis. These recurrent meningitis, you have to treat the underlying cause. Length of antibiotic treatment is not different. And there is no guidelines for prophylactic antibiotics. Vaccination is advised for immune compromised persons. But the aim of treatment is to treat the primary cause, like the CSF fistula, complement deficiency, or dermal CSF fistulas, which is causing the organism to enter into the CSF. Then we have got the mollaret meningitis. Clinically, all features of acute meningitis will be there. And we will have polymorpho and lymphocytic CSF, mixed picture will be there. Mild increase in the protein, glucose is normal, and mollaret cells are there, and cell count quickly reduces. So this is diagnosed by large fragile mononuclear cells called mollaret cells. Next is cerebral malaria. Usually develops over several days of fever. Patient becomes comatose in 24 to 72 hours once it gets in the brain, and convulsions occur, generalized or focal, retinal hemorrhages, papilledema, fixed jaw closure and bruxism, mild neck stiffness, bipyramidal signs, decorticate or decerebrate. Then we have to do all the tests for the, if the person is coming from the endemic area, and raised ICP, short duration with seizures and stormy presentation, look for malarial parasite and do the rapid malaria test, of which all physicians will be more familiar. And so that will give the diagnosis and start the appropriate treatment. And rare causes of meningitis seen in autoimmune diseases, patients with autoimmune diseases, steroids can produce meningitis, trimethoprim can produce meningitis, and drugs like cephalosporin, ciprofloxacin, INH, penicillin, sulfonamides, azathioprine
carbamazepine, all these can produce drug-induced meningitis. Craniopharyngiomas can produce chemical meningitis. Iatrogenic meningitis following interventions, cranial surgery, many myelograms. No? So this produces rare infections with non-pathogenic organisms and mixed infections. Tuberculous infection. Even tuberculous infection can sometimes happen following procedures on the neuraxis. Then Streptococcus salivarius and epidermidis, if it is present, the doctor is considered responsible. Streptococcus salivarius comes from saliva. That means the person who did the procedure probably did not use a proper mask. And epidermidis indicate the skin was not cleaned properly. So if these two organisms are found legally, we will be held responsible. Other organisms do happen. And chemical meningitis happens with intrathecal contrast agents, drugs, and craniopharyngiomas. The take-home message is, we saw how difficult it is as you ascend the hierarchy from the emergency doctor to the neurologist based on the knowledge about sensitivity, specificity of all tests, and the importance of taking 5 samples in the CSF and using the 5th sample for special cases. Meningitis is not an easy diagnosis. So it denotes a group of symptoms and signs, and suspicion is the indication to treat. And it is a neurological emergency. We should not under-treat. You can start over-treatment. When you start, whatever you suspect, you start. Then you can withdraw by analyzing the 5th sample. And once you are diagnosed meningitis, whatever is the cause, if the patient's symptoms improve and you have less beds in your hospital, you should not convert the drugs into oral and discharge the patient. Because as the disease improves, the blood-brain barrier closes and the drug level in the CSF comes down. Because of that, the amount of drug in the CSF will be less, so acute bacterial meningitis will relapse. If you shift it to oral dose too early, it should not be done. And prevent all preventable causes using the vaccinations, chemoprophylaxis, hygiene, and good food habits. So that